A lot about different contraceptive methods yesterday and the importance of talking to our patients about contraception. Also talking to them about the potential side effects that they can have for those first few weeks to the first couple of months when initiating contraception. The more time you take talking to your patients and counseling about these potential side effects, the less likely they are to come back to you the following week, and the following week, and the following week, for 2 or 3 months, asking you about these medications and the potential side effects, and is this supposed to be a side effect or not? Now, does that mean that they're not going to come back and ask you? No, it just reduces the amount of visits you're going to have with that exact same person. And they're going to be pretty busy. In primary care, I remember when I was at Bragg, we got impaneled, and you had a patient scheduled every 10 minutes. Every 10 minutes. 8 a.m. to 5 p.m. That's a lot of darn patients. That is a lot of patients. And that means that any patient that had more than one complaint or was more complicated, you didn't have a lot of time to figure that out. So the less patients that you had on your panel, the better, because you could spend more time with each patient. What that also means is you don't have a lot of time to figure out what you're going to say to these patients, depending on which contraceptive method you're going to provide to them, and have your spiel down for your counseling methods for them. So emergency contraception. So emergency contraception, we're thinking about a patient that comes in, they either had unprotected intercourse or had intercourse, the condom broke. For some reason, they feel like they might have put themselves in a situation that they're pregnant. So sometimes even unintentional sexual advances, right? So something like rape. For these patients, you might be seeing these patients in the clinic, especially National Guard and Reserve folks. You might be seeing them in your clinic. Most of the time for active duty, those patients go to the emergency department because there are specific evaluations that they need to have done. But for some reason, this person needs emergency contraceptive. The most effective form of emergency contraceptive is going to be the copper IUD. Now, what's the problem with having an IUD or getting an IUD placed? You gotta go, you gotta get an appointment. Have y'all tried to get an appointment here? Hopefully most of you haven't, but if you had to, it's not going to be today. It's not going to be tomorrow. It's probably not going to be next week. So the emergency contraception with a copper IUD might be plausible in some areas, but it really depends on where you're at, because you have to get an appointment for placement. When you guys go into phase 2, you might be in a location that you put in a lot of IUDs. So you might get certified in IUDs. I had a shift last night. I was talking to a phase 2 student that came in, and she was talking about her women's health rotation over your BAMC. And she said the majority of the stuff that she did at BAMC was OB stuff. So that's great for like 2 or 3 days, right? But not for a couple of weeks, because you're not going to see that much OB. So she said she never put in an IUD, never put in an implant, so has no idea how to do those things. If you're able to, when you're doing your rotation in phase 2, try to get certified on it so that you can then open this up for patients that need potentially insertion of IUD outside of emergency contraception and in association with emergency contraception. So most effective, has the highest success rate, 99% from the beginning. Insert this, and is much less likely to get pregnant, and can be inserted for up to 5 days after that, either unprotected intercourse or unwanted intercourse. Otherwise, we have the emergency contraceptive pills. We have a couple different pills that we can offer. So the Plan B, that is an over-the-counter medication, comes in one single dose. So the person can go, usually they have to go up to the pharmacist and ask for from the pharmacist, and then they can give them the Plan B, so one dose of that. Plan B is most effective if taken within the first 72 hours, so 3 days or so. Again, can still be effective up to that 5 days, but you can see here, we go from a much higher effective rate down to about 58% every time it's taken after that 72 hours. So by the time we get to the 5 days, we're probably around 50 or high 40% for effectiveness. So not truly all that effective, after that first 3 days. 94% effective before if you get within that first 3 days. The other thing about the Plan B that's important to note is those patients with those higher BMIs, BMI greater than 30 is not, the research says it is not very effective. And so it may not be a consideration for their patients. If it's the only thing that's available, then it's worth trying, but we have to counsel our patients that it's not effective in patients that have those higher BMIs. We have something called the Olapristal or Ella. Olapristal is a prescription medication. Can it be effective for up to 5 days? But again, it's more effective in that first 72 hours or so. 98% effective, and then it goes down to like 85% effective. So still more effective than levonorgestrel, which is the Plan B, but again, must have a prescription. So these patients, you have to come to you and get a prescription for this. You think about BMI associated with that as well. So it can still be effective from 30 to 35 BMI, but greater than 35 BMI, the research shows that it's not effective. They're not likely to have good protection with the Olapristal. And then we have something called the USP regimen. And what the USP regimen is if these patients are already on combined oral contraceptives, they're going to take those combined oral contraceptives and they're going to take them in two different time periods. They'll take an initial dose, and then 12 hours later we'll take another dose. But the dose that they need to have is they need to have 100 micrograms of the estrogen component, and then 0.5 or equivalent 0.5 milligrams of the levonorgestrel component. So you've got to look and see what birth control they're on. If they're on the higher dose estrogen component, they could take 2 in the morning and then 2 12 hours later. But if they're on that lower dose, that 20 to 30 or 35, they may have to take 3 pills or 4 pills or 5 pills. So you'd have to first determine what combined oral contraceptive they're on. You've got to look at the estrogen component of that, you've got to look at the progesterone component of that, and then you can guide these patients on how to take them. But they can use their own contraceptives if they're already on oral contraceptives or have access to oral contraceptives. This is less effective than both the Plan B and less effective than the Olapristal. But again, if they have access to nothing else, it's better than doing nothing. When we talk to our patients about emergency contraceptives, we need to talk to our patients when we provide these contraceptives, or even when patients are coming in for routine evaluations. We can talk about, in the event that you find yourself in a situation that you need emergency contraceptive, come and see me immediately, right? If it's midnight, you come and see me the next day. But the sooner I can see you, the more we can offer. Okay, and the better likelihood we have of being successful in avoiding this unintentional or unwanted pregnancy. The Olapristal, that's the Ella, prescription only. You can provide prescriptions, and I think the way it is nowadays, even if you're in the military, wherever you're stationed, you're supposed to have a license in that state. And that's kind of nice, because if you moonlight somewhere, you already have a license. But also what that means is, if your pharmacy does not carry this prescription, you can write a prescription for these patients to get this medication off post as well. Okay. The copper IUD, they must visit a healthcare provider for that. And it may not be you. If you're not certified in inserting IUDs, it's not going to be you. You've got to refer them somewhere else that they can insert the IUD, and it needs to be done within 5 days. We don't have ongoing protection with the emergency contraceptive. We are providing protection right now. So then after we provide emergency contraceptive, we've got to say, what are we going to do next? How are we going to help you in the future to help prevent this situation from happening again? If an IUD was placed, if they choose to keep the IUD in place, that's fine. Remember, once they put the IUD in, we have immediate contraception benefit. Okay? So if they choose to keep the IUD in place, then that's how we don't need additional contraception. If they opt to have the IUD removed, there's no specific time period that they need to have the IUD, but most of the time what is recommended is to get removed after the next menstrual cycle. Okay? That's kind of the rule of thumb. But if you look it up in the literature, you can come and argue with me and say, well, it doesn't say that. I agree. There's no argument to be had, but I'll just say the rule of thumb is they'll typically wait until after the next menstrual cycle. So if that's the case, they want the IUD out, but the IUD was used or the Plan B was used, then we can start any other contraceptive. We can start any other hormonal contraceptive. Okay? We do recommend 7 days backup contraceptive, especially if we use the Plan B, not necessarily with IUD. But just keep in mind, just 7 days we talk to our patients and we don't have to memorize which one is with 7 days and which one is that. If the ulipristal is used, so ulipristal is a combined hormonal contraceptive. So we want to make sure that we wait for 5 days before we have hormonal contraceptive use. So we don't want to give these patients combined hormonal contraceptive after that because it decreases the effectiveness of that ulipristal. If they want a non-hormonal contraceptive like the copper IUD place, we can certainly have that or arrange that to happen. Okay. And then again, 7 days backup is recommended. Specifically with the ulipristal, you want to avoid any sort of hormonal contraceptive in addition because it decreases the effectiveness of the ulipristal. These patients might be coming to see you postpartum for contraceptive. Most of the time that is taken care of by OBGYN, and most of the time that is going to occur at their 6-week follow-up. Okay? So for patients that are breastfeeding, they say breastfeeding can be protected for up to 6 months. Okay? That's great. And that is in the majority of patients. I certainly had a patient maybe about 3 weeks ago that came in, and that was not the case for her. She was like baby number 4, and the same thing happens every time to her, is she feels like she's protected with the breastfeeding, and next thing you know, about 4 months in, she's pregnant. And so we want to think of the breastfeeding as being protective, but that's not for all comers. So if someone is like, I definitely do not want to get pregnant, then we can put them on contraceptive. So what we can do is, so the literature says that immediately postpartum, you can do an IUD, you can do implant, you can do depo, you can do progesterone-only pills. So what do all of those have in common? What do they have as their agent for protection for contraception? Progesterone. Okay, we don't have estrogen. We do not do estrogen immediately postpartum because estrogen increases the risk of what? Blood clots. The highest risk for blood clots, DVTs and PEs, is actually that early postpartum period. So even though the literature says immediately postpartum we can do this, all of these progesterone-only contraceptives, the recommendation by OBGYN and by American College of Gynecology is that we wait until that 6-week mark. Okay? Definitely we have that protection, that postpartum period, that 6-week mark. So the recommendation is we can still do any of these things, the IUD, the implant, the depo, progesterone pill, but usually wait until that 6-week mark. If you insert an IUD earlier than that, there's a high rate of expulsion because remember we've had cervical change during that pregnancy and then ultimately during that delivery. Even if they delivered C-section, we still had changes in that cervix dilated. And so we don't want to insert an IUD and then have the IUD exposed because we are still undergoing those cervical changes. Okay, so for the implant, we can certainly do that, but again, we want to make sure that these patients are breastfeeding, have good breast milk production, they've got time that they're been breastfeeding for a while, because even though the literature says that progesterone does not decrease the production of breast milk, there are some patients that it does decrease the progesterone. Progesterone does decrease breast milk. In the majority, we're not going to have that problem. But the thought process is if we allow them to wait till that 6-week mark, we have good production of breast milk, they're able to breastfeed, and then we can talk about contraception without running the risk of them getting pregnant in that first 6 weeks. Now, once we get beyond that 6 weeks, we can actually do any contraceptive. We can add those combined hormonal contraceptives with that estrogen and progesterone because the risk for DVT and PE is significantly lower once we would get beyond that 6 weeks. If someone comes in, they've had a miscarriage or they've had an elective abortion, Okay? They can ovulate as soon as 2 weeks after the miscarriage or the elective abortion. Okay? So we want to make sure we talk to our patients immediately about contraceptive post-miscarriage or post-elective abortion, and we can put them on any sort of contraceptive. Now, that being said, if they had, if they're in that couple of weeks after the miscarriage or the abortion, what do we think is going on with that cervix? We're still having that cervical change. So if they opt to do an IUD, they may still run that risk of expulsion of the IUD for that first month or so while the cervix is going back to the normal size. Because even if they miscarry, the cervix is going to open up to allow that miscarriage to occur, and then the cervix is going to take a week or two to go back to the regular size. So just think about that when you're providing counseling regarding contraception for post-miscarriage or abortion. We want to make sure we review or at least know where to find the USMEC, the USSPR. You want to know that's that companion document. Know where to find those documents. You want to use those in real life. Okay? We want to understand which contraceptives can be used in which situations and how to counsel our patients about these contraceptives. Not just how to use it now, but what do they do about it when that patch falls off? Or what do they do if they miss a dose? Provide handouts to your patients so they're less likely to come back and see you or send you messages on endometriosis. Remember our 1s and 2s for our USMEC, those are good to go. Our 3s and 4s, you want to try to avoid those 3s and 4s. And for your examination, you guys may be wondering, do I have to memorize that USMEC? Yeah. No. No. If there's a question on your exam and it requires the use of the USMEC, I'm going to give you the USMEC. So it'll either be embedded into your question, or I typically hand out copies of the USMEC in color, so you can use that. Again, you know, my thought is that if you have the documentation, I expect you to use that in real life. I want you to use that. So you guys need to know where to find that. All right, so that is it for our contraceptives. Let's move on to our abnormal uterine bleeding. So abnormal uterine bleeding, this is going to be like a bottle of wine, and then the cork is coming out. And that's how some people feel, because when you have this abnormal uterine bleeding, they're just constantly bleeding. They can't even go out of the house because every time they stand up, they just have all this significant amount of bleeding. We've got our TLOs and our ELOs. We're going to focus on some major or primary causes of abnormal uterine bleeding. And then some treatments for the abnormal uterine bleeding as well. So let's think about what we talked about yesterday and a little bit today. You've got a 27-year-old female coming in for chronic pelvic pain, diagnosed with endometriosis. And we have not talked about endometriosis, but endometriosis is endometrial lining. The cells are outside of the inside of the uterus. So you have those endometrial cells that are on the outside of the uterus, can be around the ovaries, can be all the way up into the pleural cavity as well. So the endometriosis, and she says my pain is really bad, especially during my menstrual cycle. She does not want to have any pregnancies in the near future. So when we think about contraception for her, we say that her symptoms are worse during her menstrual cycle. What contraceptive might we say would be beneficial for her to take? So even if you don't know these names, if I give you an option, monophasic, triphasic, extended cycle, continuous cycle, or quadphasic?
Continuous.
At least an extended cycle or a continuous cycle, right? Because then we don't have the menstrual cycle. If we have extended cycle, we have a menstrual cycle every 90 days. If we're continuous, we don't have it all. 365 we're having it active. So something like a Seasonique, Seasonique would be good for your extended cycle. For these patients with endometriosis or significant signs and symptoms during their menstrual cycle, the less they have their menstrual cycle, the less signs and symptoms you're going to have. So this would be a really good question to kind of hone in on, like, there's about 4 or 5, maybe like 3 slides on if someone comes in and their complaint is acne, what might be the best medications? If their complaint is dysmenorrhea, what might be the best contraceptive? There's about 3 or 4 slides that talk about that. This will be a question similar to this that comes off of those slides, right? So make sure you look over those slides. Our 19-year-old comes in, moderate acne, not improved with over-the-counter treatments. Okay, she is interested in a contraceptive option that will not only provide contraception, but also help with her acne. Now, you have to think about the progesterone component of this, because that's what helps with the acne. And we talked about the 4 kind of tiers of progesterone, right? Or classes of progesterone. Which of those 4 is best for acne or hirsutism? What has the least androgenic properties? So the 3 or the 4? The 3rd or the 4th generation progesterone only. Okay, so if you remember something like drospirenone might have been on there for your 4. Okay, so again, this would be something similar. When you're looking at these questions and when you're studying which of these progesterone onlys, which would be better for these specific situations. So something like a Yaz. Okay, so it's not the estrogen component, it's the progesterone component. What else does drospirenone help with? You guys remember it has like a spironolactone, so it helps with weight gain and that bloating as well. Tier 1 contraceptives. Which ones are our tier 1 contraceptives? Alpha, right? Implants, IUDs, and then male and female sterilization. And that's at less than 1% failure rate for most effective contraceptives. Okay, and then the copper IUD. How does that work, the copper IUD? B, local endometrial inflammatory response, right? So it does not prevent ovulation. Okay, it doesn't really cause endometrial atrophy. That's really going to be with your progesterone, your levonorgestrel IUD. All right, very good. Before we can talk about abnormal bleeding, let me remind you what normal bleeding is. So normal bleeding, and we talk about our normal menstrual cycles, is cycles that are predictable. They occur at the same time every single month. They have about the same amount of menstrual bleeding or blood loss that's associated with each cycle. Usually they're going to occur every 21 to 35 days. Okay, last between 3 and 7 days with the amount of blood loss between 20 and 60 ml. So that's what we consider normal. So then of course abnormal is anything out of those parameters. Okay, so we have irregularity in our menstrual cycle. So the frequency changes. It's no longer consistently every 28 days. How long it lasts can change. It used to last 3 days, now it lasts 10 days or 12 days. And then the volume of flow, how much bleeding is occurring. I used to use, 4, 5, or 10, 15, 20 sanitary products throughout my menstrual cycle. Now I'm using 40 or 50 sanitary products, or I'm only using 1 or 2. So it could be worse or it could be better. It's going to happen. You're going to see this. Many times throughout the week of seeing patients, you're going to see abnormal uterine bleeding. It occurs about 1/3 of women. And it is going to be more common at those extremes of age when we don't have that HPO axis is either immature or towards the end when we go towards menopause where the HPO axis is kind of given out a little bit. Ovaries are not as functional. We're going to have change in our hormones as we get closer and closer to menopause. Now, you may notice in some older literature, we used to use those older words to identify different things that are going on with the menstrual cycle. So dysfunctional uterine bleeding is what this used to be called, but now it's called abnormal uterine bleeding because people don't like to be called dysfunctional, I guess. I don't know. Oligomenorrhea. If you just think about oligomenorrhea, you're like, what does that even mean? Well, oligomenorrhea means light menstrual cycle, but they just expected us back in the day to know what that meant. Same thing with menorrhagia. I will tell you, until my dying day, I would have to keep looking up menorrhagia and menorrhagia. Menorrhagia versus metrorrhagia. And then sometimes it's menometrorrhagia. And then it's spelling that on like the National Spelling Bee or something, right? So it was terrible. It didn't give any indication of what they meant. So menorrhagia is now, it means heavy menstrual bleeding, and that's what we call it nowadays. We just say they have heavy menstrual bleeding, right? Greater than the 60 ml, really greater than 80 ml. But, and then metrorrhagia, intermenstrual bleeding. So if someone comes in and says, well, I had my cycle, and then about 2 weeks later, I bled again. That's intermenstrual bleeding. We no longer have to know it's menorrhagia or spell that it's menorrhagia. But you may see this terminology. I was actually looking at something just a little while ago, and it said metrorrhagia. I was like, oh. So, how we define the menstrual cycle dimensionally is by using these words: frequency, regularity, duration, volume, intermenstrual. Okay, so when is it occurring? When we ask our patients about, when they come in with this abnormal uterine bleeding, these are the words we want to ask them. Well, how frequent are your menstrual cycles? Okay, are they occurring less than every 21 days, meaning they're frequent menstrual cycles? Or are you having greater than 35 days in between menstrual cycles? That would be considered infrequent menstrual cycles. Okay? What is the regularity? Are you having it every 20 days, 28 days, or not? Are you amenorrheic, meaning no menstrual cycle for the last 3 months, if they're having regular menstrual cycles before? Or for 6 months, if they have a history of irregular menstrual cycles? Okay? Are you having irregular menstrual bleeding, meaning that there's greater than 20 days difference between your cycle lengths? What about the duration? Greater than 8 days is considered prolonged, and then less than 2 days is considered shortened. So that's how you would write this. Patient comes in, they complain of, they mention menstrual cycle lasting for a day and a half, consistent with a shortened menstrual cycle. Because here's the problem with you just saying this is a shortened menstrual cycle. Most people don't keep up with literature because they're busy seeing patients, right? And so it's better to quantify. What do you mean by that? Yes, this is what the literature says, but just write it out and quantify that in your note, so that when you come back and look at your note a year and a half later and you have not kept up with the literature, you can be like, well, what did I mean by that? I meant 2 days because that's what I put on. Okay. And then volume greater than 80 cc's is considered heavy menstrual cycle, and less than 5 cc's is considered light menstrual bleeding. Okay. And then we talk about intermenstrual bleeding. That is bleeding in between the cycles. But when females come in and they say, I'm having a lot of bleeding, I'm really, really bad, it's hard for us to get a good idea of what that really means to them. So we can quantify that and say, okay, well, are they having more than 80 cc's? Are they having less than 5 cc's if we're talking about really light bleeding? But we can quantify that by asking them specific questions. Okay? So how often do you change your sanitary products? When you change the sanitary products, are they completely soaked, or are you just changing them because you feel like you're bleeding a lot, but then you take out the sanitary products or you change the sanitary products, there's not a lot of bleeding on there. Okay? Are you passing clots? If you're passing clots, how big are they? How often is it occurring? What about any systemic signs or symptoms? Are you having lightheadedness, palpitation? When you go from sitting to standing, do you feel like you're going to pass out? Vital signs, are they tachycardic? That might in fact indicate they are having significant bleeding. But patients come in and they say, I'm bleeding a lot. It's really hard to quantify that, so we've got to get more information. And usually they don't know how to provide us more information, so we've got to ask very pointed questions for us to be able to quantify them in our mind how much bleeding this is. There's also something that's kind of weird, but it's called tampon math. Okay, so you could show this chart to your patient, and you could say, if you were to kind of think about your sanitary products over the last several days of your menstrual cycle. Okay, again, were they soaked through? If so, then we're going to give them these points. So we assign points to these specific sanitary products. And once we come up with these points, then that helps to determine, okay, how much are they bleeding? Who's going to do that? Nobody. Nobody's going to do that. First of all, I'm going to tell you, women are not staring at their sanitary products. If they're using a tampon, they're taking it out and they're putting one in. They're not like figuring out how much bleeding was in there, right? Same thing with their sanitary napkins. They're just changing them out because they feel like the napkin is full, but they're not really like studying these products, right? So I wouldn't pull this out and expect really good answers from your patients on this. Instead, I'm not going to ask those other questions. I'm going to look at their vital signs. And if there's any indication that they are bleeding a lot, I might grab some labs on them. That kind of helps me out as well. Okay. Remember, when we think about the amount of fluid sanitary products hold. Okay, so I talked about this a couple of classes ago, but a super absorbent tampon or pad, super absorbent. How many cc's does it hold? Like 10 cc's. So one saline flush. If it's regular, 5 cc's. So really, these patients have to go through several of these. But we say greater than 80 cc's in a menstrual cycle is considered a lot. If these patients are changing their sanitary product 4 or 5 times a day and it's soap, then they very well may be over that 80 cc's. Okay? So figure out what kind of sanitary products they're using and an idea of how soaked those are. But I wouldn't show them this. They would probably think it's a little bit crazy. So abnormal uterine bleeding, we think about this as a diagnosis of exclusion. Diagnosis of exclusion, meaning this. If someone comes in and they have polycystic ovary syndrome, okay, and then they have abnormal bleeding associated with that. Well, their diagnosis is an abnormal bleeding. Their diagnosis is polycystic ovary syndrome, but this is a secondary effect of that polycystic ovary syndrome. Okay? So it's a diagnosis of exclusion. We want to try to identify the underlying cause of what this abnormal bleeding is. Okay, according to the International Federation of Obstetrics and Gynecology, or FIGO, they actually made up this kind of funnish acronym to help us remember the most common causes of abnormal uterine bleeding. So we have structural causes and we have non-structural causes. We use PALM as our acronym for our structural causes, and we use COIN as the cause of our non-structural, or the acronym for our non-structural causes. And when we think about abnormal bleeding, we're really going to hone in on those patients of reproductive age, because the majority of these issues are associated with estrogen production, which is usually pretty high in our reproductive age. If you have a patient that's postmenopausal and they're coming in with bleeding, that's called postmenopausal bleeding. And that is a whole nother evaluation and a whole nother risk factor that's associated with that. So we really kind of focus on the reproductive age patients. But 25% of these patients are going to come in, they're going to have that structural cause. So the structural cause could be polyps, could be adenomyosis, leiomyomas, which are fibroids, okay, or it could be some sort of malignancy or hyperplasia. We use that PALM as our acronym to help us remember the structural causes. And that means about 75% of these patients are going to come in and have non-structural causes. And we can use COIN as our acronym to help us remember those non-structural causes. Do they have some sort of underlying coagulation disorder or on medications that may cause coagulopathy? Okay. What about any ovulatory dysfunction? We talked about anovulation before, how that can cause some irregular bleeding. Endometrial, so if they have endometrial infection or inflammation. Iatrogenic. Iatrogenic means we have done or something that the patient was introduced to has caused this abnormal bleeding. Not yet classified, because that is there as a catch-all, right? Well, I didn't say that because it was not yet classified, but now it's in there. So it's a list of a million different things that we haven't really thought of yet, but eventually we'll think about it. And this comes from our reference book, Williams, and they use the exact same things. They use PALM and they use COIN as the remembering, way to remember the structural and non-structural causes of abnormal bleeding. When these patients come in, it's important to understand their age, and the different things that can happen at certain age groups. So if you have a baby, mom brings baby in, and baby is, 4 days old. Can baby at 4 days old have vaginal bleeding? Yeah, actually, I've seen it in many cases. Okay, for babies for neonates up to 2 weeks, they can have some degree of vaginal bleeding, and that's from estrogen withdrawal with mom. But guarantee, if a 4-day-old baby is having vaginal bleeding, parents are going to bring that baby in to see you. Okay, and it might be in the clinic that you're working in. It might be when you're doing your rotation in the emergency department, or it might be an area that you move on. That is not unusual for that to happen. Okay? But when you think about patients, maybe in young toddler up to pre-pubertal, so maybe 10 or 11 years old, if they come in with vaginal bleeding, that would be a little bit more unusual, right? A little bit more concerning. Is if there has been some sort of trauma, there's just some sort of foreign body insertion. Those patients need to be evaluated probably by an expert. Okay, so probably we oftentimes get a good history from the parents, of course, and really try to get a good history from the child. But we're much more concerned for those patients that something has happened that is causing this to occur, unless we believe that there's a history or there's a family history of some coagulopathy that may cause this. Patients in that reproductive time frame, or even if we talk about that early reproductive time frame and the late reproductive time frame. Remember, immaturity of the HPO axis, so we can have those anovulatory cycles at the beginning and anovulatory cycles at the end of reproduction. Those patients often have irregularities in their menstrual cycles. And then for the majority of our reproductive time frame, we should have regular menstrual cycles. Women should have regular menstrual cycles. If they don't, those patients need a workup. And we need to identify why they're not having regular menstrual cycles. Why are they not bleeding very much, or they're bleeding excessively? Why are they having infrequent or frequent menstrual cycles? Patients over the age of 45. Now 45 is a little bit early for menopause, but certainly really in that perimenopausal time period is 45. Those patients over the age of 45, they have abnormal bleeding. They could be from anovulation, but if they have really significant risk factors for prolonged estrogen exposure, so like early menarche, maybe that estrogen secreting tumor, maybe that anovulation their entire life, those patients we got to be cautious of. Because oftentimes what will happen is we'll think, well, it's just anovulatory, or you're getting to the point of going through menopause, and you're having these cycles. And the reality is, if we don't get a good history, it's endometrial cancer. We don't want to miss that, right? So don't just push it off as they are, ending their reproductive life cycle. Make sure you get a good history. And if there's any indication they've had prolonged estrogen exposure, especially with those anovulatory cycles, then we want to make sure we work those patients appropriately. And then postmenopausal, you should not bleed postmenopausal. Should not bleed postmenopausal. That's always abnormal, and it's always scary, and they must be worked out for the postmenopausal, for those postmenopausal periods that we're bleeding. So you have this 44-year-old female come in, P3, means she's had 3 prior deliveries. She had 2 years of some degree of irregular bleeding. She bleeds out sometimes 2 weeks out of the month. Okay? And the amount of bleeding that she has varies. Sometimes it's spotty, sometimes it's heavy. She has these accidents where she bleeds through the protection that she's wearing. She always has to wear a pad. She's frustrated, not necessarily with life, but certainly with this abnormal bleeding when she can't continue on with her daily function. She's tired, she's fatigued. She says to you, as my primary care, fix me. Fix me, right? Well, first of all, you've got to think about what is her age, okay? What are her risk factors? And did she give us the information? Go back one second. Did she give us the information? What is our frequency? What is our regularity? What is our duration? What's about the volume or the amount? We want to get those questions answered, because it provides more and more information about the amount of bleeding that she's having. Okay, so for this patient, what is her issue? Is she having heavy menstrual bleeding? Sounds like she might be having heavy menstrual bleeding. Is she having intermenstrual bleeding? Sounds like it. Is she having light menstrual bleeding? Sometimes. So all in all, she's just having a form of abnormal uterine bleeding, which is a mixture of all sorts of things going on. So for this patient, we think about, abnormal bleeding, and what is the potential cause then for her abnormal bleeding? She's 44. What lab test do we want to do? Gotta do that pregnancy test, right? Gotta do that pregnancy test. She is still well within the time period that she can get pregnant. She might be having mixed ovulatory and ovulatory cycles. Okay, but we need to get an HCG. But we might need to get the rest of these labs as well. Okay, but we don't want to forget HCGs. Even though she'll swear up and down, there's no way I'm pregnant. I'm pretty sure I'm not going to go through menopause. It's impossible. It's not impossible until she's not had a menstrual cycle at all for a year. Then it becomes impossible. But until then, that's not the case. We run her through HCG and add additional labs based on her history and physical exam. So those PALM structures, the structural causes, we use that PALM acronym, the polyp, adenomyosis, leiomyoma, and the malignancy, endometrial hyperplasia. We think about those as very estrogen-dependent lesions that can happen. And that's why we're going to see these more often in the reproductive time frame. Okay, so let's go through these a little bit. So the first one, that P in your palm, is the endometrial polyps, or AUBP is how that's typically written. So endometrial polyps, these are hyperplastic growths. They kind of grow out, it looks like a cauliflower on a stalk. And they can go outside of the uterus or they can go inside the uterus. And either way, they can cause a significant amount of bleeding, but even more so when they're growing on the inside. So this is a giant polyp on the outside, and this patient has several polyps on the inside. You can see one here and one here. About 25% of women will have polyps, and the amount of bleeding that they have will vary from person to person. But the majority of times it's going to peak around 50. So they may start having some bleeding in their 40s and usually peaks around the age of 50. The most common bleeding that they're going to complain of or be concerned about is intermenstrual bleeding. So I had a menstrual cycle, seemed to be okay, seemed to be normal, but then I had bleeding in between that before my next menstrual cycle. We diagnose this typically with an ultrasound. And most of the time it's going to be a transvaginal ultrasound. If for some reason the patient can't tolerate the transvaginal ultrasound, they can do a transabdominal. It's just hard to see polyps. Even on transvaginal ultrasound, it's hard to see polyps. But if they need to, they'll do a transabdominal. Sometimes, if they really think that there's something going on here, they can't see it with a regular ultrasound, then what they'll do, they'll either do something called a saline infusion scan or sonohysterography. And what they'll do is they'll take an ultrasound probe, it's an ultrasound vaginal probe, and they'll take a pipette and they'll actually infuse fluid into the uterus, okay, and they're going to try to highlight any abnormal lesions in the uterus. Okay. What doesn't help us is cervical cytology. This is occurring inside the uterus. Cervical cytology, do you guys know what that is? We're taking a scraping of the external os. Okay, so we've got the internal os that goes into the uterus. External os is what we can see on physical exam. Cervical cytology, that's what we're using for cervical cancer screening. So if you do a cervical cytology, that's not going to help us because the problem is either inside the uterus or is on the outside of the uterus. But it's not a problem at the cervical level. It's not beneficial. You need to have some sort of imaging. This is an example of a saline infusion scan, very similar to a sonohysterography. And this first picture, this picture under alpha, what I'm going to tell you is this right here, this dark line out here, that is the uterus. Okay. This inside here, this is the endometrial line. So when you think about the uterus, okay, it's kind of this pear-shaped, right? But inside we've got the lining of the uterus. And the lining of the uterus comes all around the inside. And it kind of meets in the middle of the uterus. So right here, like this. So that's what we're seeing here is where the two sides of the uterus are kind of meeting in the middle. Well, once we infuse saline, okay, into this uterus, we are now separating the two sides of the inside of the lining of the uterus and endometrium. We're now opening that up with the fluid, and you can see this is the same patient. They have a big mass right here on the posterior portion of their uterus. Can you see that over here? I mean, retrospectively, you can come back and say, well, maybe that's right here, right? But I don't think y'all saw that. I don't think so. But we clearly see it here. And that's the problem with polyps. So sometimes the polyps will appear just like this, where we just kind of almost looks like we have thickening of the endometrial stripe, okay, where it's thicker than normal. And so when we do this saline infusion or infuse some sort of fluid in here, we can highlight any sort of lesion or mass that's actually there. And that's causing the appearance of thickening of that endometrial lining, but it's really from that mass. So that's it for polyps. We look at cauliflower stalks, intermenstrual bleeding, and that's our P. Our A of our POM, our structural causes, is something called adenomyosis. Adenomyosis. This is actually interesting because for some reason and somehow, we don't really know exactly how, but the lining of the uterus, those uterine cells or the endometrial cells, somehow get into the muscle portion of the uterus. They move outward into the muscle wall of the uterus. So now we have endometrial cells instead of just inside the lining of the uterus and the endometrium is now outside into the muscle of the uterus. So these patients oftentimes are going to come in and present with significant pain, okay, along with abnormal bleeding. More commonly seen in women 40 to 50, but I'm telling you, you're going to see these patients, this in patients in their 20s, 30s, 40s, and early 50s. The problem with their 20s and 30s is oftentimes they would just discount it maybe as just a dysmenorrhea, take some anti-inflammatories, because we don't have a lot of endometrial cells in the muscle area at that time. Over a period of years and years, we get more and more adenomyosis, or more and more of those cells migrate out to the muscle, and these patients become more and more symptomatic. Well, to the point where they're in their 40s, now they're very symptomatic, and usually that's what prompts them to come and visit you, because this has been going on for a while, but now it's really bothersome. On exam, right, these patients may initially be asymptomatic, but usually by the time they come to see you, they're going to have that abnormal bleeding, and they're going to have what we call a globally abnormal or globally enlarged uterus. So just take a look at this picture here on the very top portion. This is the fundus of the uterus. And the fundus of the uterus is what we are palpating on our bimanual exam. We've got two fingers in the vaginal vault, we've got our other hand on top, and we're pushing down just around the suprapubic area. We're pushing down, and we can feel the fundus of the uterus. Well, what we're feeling with patients with adenomyosis, it kind of feels like kind of lumpy. It's very globally enlarged and abnormal appearance, but not like a focal area that's enlarged. It's globally enlarged. And we can kind of see that here by looking. And that's because those endometrial cells, okay, are enlarging in the muscle portion of the lining of the uterus. It also would depend, of course, on what time of the menstrual cycle you're doing this examination, right? If they're in the bleeding phase, where they're supposed to be shedding the endometrial lining, okay, well, guess what? These cells don't know they're in the muscle belly. They have no idea they're in the muscle. They just feel like they're endometrial cells. They're doing what they're supposed to do. They're supposed to be shedding. So we're really going to have significant pain and enlargement during those time periods. Okay. Not only can these patients have abnormal bleeding, they may also have pain with intercourse, and of course painful bleeding, painful menstrual cycles as well. For evaluation, the tool of choice is going to be a transvaginal ultrasound. Transabdominal only if the patient cannot tolerate a transvaginal. The transvaginal ultrasound is going to be your study of choice. Okay, endometrial biopsy. So think about an endometrial biopsy. Endometrial biopsy, we're coming in through the external os, through the internal os, and we're taking off biopsies of the inside lining of the uterus. That doesn't tell us anything about the muscle of the muscle portion of the uterus. It doesn't tell us anything. It tells us only about the lining of the uterus. So most of the time we think about endometrial biopsy, it's not going to be beneficial. Just because it's normal doesn't tell us anything. It doesn't tell us anything about the muscle portion of the uterus. So frequently non-diagnostic, because this is in the muscle of the uterus, not the lining of the uterine wall. And then MRI. Actually, MRI is pretty darn good. But have you tried to get an MRI? How long does it take to get an MRI? Once someone has an MRI, well, how long are they at the MRI? Some people can't tolerate the MRI because it's a closed space. So there's lots of confounders for MRIs. But if we have to get an MRI, because ultimately an ultrasound is done, and ultrasound's like, well, I don't know, maybe they have adenomyosis, not really sure, okay, then the next treatment, the next evaluation would be an MRI, so it's just difficult to do. So it's not your initial study. Doesn't mean we never do it, but it's not your initial study. The initial study is going to be an ultrasound to assess for adenomyosis. Treatment for adenomyosis. Most of the time, these patients do okay with medical treatment. Okay, it's most effective kind of in the short term, but a lot of times over a period of months and sometimes years, the medical treatment, the oral medications become less and less effective. So contraceptives are typically used as our first-line treatment. Progesterone, because remember this is more of an estrogen responsive issue with estrogen. So a lot of times we'll think about progesterone, like the levonorgestrel IUD is used pretty frequently for adenomyosis. We can use combined oral contraceptives. Remember, combined oral contraceptives can have both estrogen and progesterone. So we'd like to use a lower dose estrogen component on those combined oral contraceptives. Sometimes a medication called GnRH agonist, like a leuprolide, can be used, but the problem with GnRH agonists is menopause signs and symptoms. Okay? So these patients are already miserable, and now you want to make them have signs and symptoms of menopause, it makes them even more miserable. But what will happen is they may try these patients on GnRH agonists in preparation for surgery. So like, hey, look, you're not really responding to other medical management. Let's try this. Let's try to get your symptoms under control. Let's see how you do with the GnRH agonist. If you can't tolerate it, then the next step would be surgery. So classically, many of these patients end up in a hysterectomy. Okay? Not the first treatment of choice. Not the first thing we do. We don't just go and just do hysterectomies on everybody. Okay? This is after they failed medical management. Oh, I think I'm so confused. Are we time? Is it time? It's time. All right. Great. Our L in our palm, still a structural cause, and our L stands for leiomyoma, aka uterine fibroid. Very, very common, affects up to about 80% of females, and again, very estrogen dependent. So a lot of these patients tend to be asymptomatic at the beginning of developing these fibroids, because these fibroids are bigger and bigger and bigger when their symptoms start to appear. So they may have a little bit of abdominal bleeding initially, but some of these fibroids, depending on where they're located, may have significant bleeding or even significant mass effect associated with them. There's several different types of fibroids. The main ones we see are intramural fibroids. Okay, intramural fibroids, you can see it that's out here in these ligaments over by the ovary. Okay, we have submucosal. Those submucosal ones, those things bleed terribly. Like bleed to death terribly. These patients will come in just hemorrhaging. So you have these subserosal, those might be able to be palpated on, again, your bimanual exam, by palpating that fundus, because those are located up on the top of the fundus. But what you're going to see, how that feels differently, is this is more round and rubbery, and it's more localized, as opposed to that globally enlarged when they're going to have adenomyosis. Again, sometimes these patients have mass effect, and from that mass effect, they may have things like incontinence, constipation, urinary frequency, depending on where this leiomyoma is located in the uterus. Bleeding is a very common sign and symptom. May not be hemorrhage at first, but depending on where it's located, the bleeding is worse and worse and worse over time. These patients may also complain of pelvic pain, fullness, and again, maybe infertility, especially if they're submucosal, so inside the uterus. that may prevent implantation of that trophoblast. On exam, well, they might have that rubbery type feeling, that irregular mass that can feel kind of more focal. And then our modality of choice for evaluating this patient with abnormal bleeding, or maybe even an abnormal exam, would be a transvaginal ultrasound. Transabdominal, if that transvaginal is not tolerated. Sometimes these fibers can be so big you can't do transvaginal because you can't insert the long radiographic wand to be able to do it. And so if they need to, they'll do a transabdominal, but ideally a transvaginal. For other radiologic studies, CT. CT, we're not doing that specifically to evaluate for uterine fibroid. We're not doing that in the setting of these patients coming with abnormal uterine bleeding. We may do a CT if they're having pelvic pain, a lower abdominal pain, to help us assess that, but it's not a study of choice to assess somebody with vaginal bleeding. If they have vaginal bleeding, it needs an ultrasound. If you identify this on CT, because if patient come in for other signs and symptoms, and you did a CT and it showed you the fibroid, guess what you should do? You should order a vaginal ultrasound. Okay? So once we identify, so in the emergency department, someone comes in, I do a CT, it's abnormal. We turn it right back around, they're going over to ultrasound, they get an ultrasound, and then they're going to come back and see me. Because I can't talk to my consultant if I don't have the proper study. Yes, the CT may show the uterine fibroid, they may show the uterine fibroid, but it doesn't give me the information or the consultants the information they need about the uterine fibroid location and potential issues they may see associated with that. So ultrasound is going to be your study of choice. Now, when we think about management for these patients with uterine fibroids, we initially start often with medical management. Okay, medical management depends on the degree of bleeding that they have, or depends if they need anything further than medical management. So these patients will come in, I've got this bleeding. You say, okay, I'm going to put you on some medication. Usually we can think about levonorgestrel IUD may work, depends on where the fibroid is located, right? So we've done the ultrasound, we said this is a fibroid, we put them on medication. If they have a large enough fibroid, what could that fibroid potentially do to that IUD?
Push it out?
Push it out. Push it out. So I still see the majority of the OBGYN folks that I work with at BMC, they're still hardcore for this IUD. But don't be surprised if you end up having expulsion of the IUD from the uterine fibroid. So the other option is combined oral contraceptive, so the birth control pill, okay? And that will help reduce the amount of bleeding that they're having by putting them on a consistent estrogen and progesterone. The other thing to think about is while we're managing these patients is let's do an initial H&H. Let's do an initial CBC. Let's see what that CBC is at, because they may be a little bit anemic depending on how long they've been bleeding. The problem is if we don't have an initial CBC and those patients come back in 4 weeks from now, 6 weeks from now, 8 weeks from now, and they're like, I'm not any better, like I'm still bleeding, and now we get an H&H, we don't know where we started from. Right? So they're probably going to be anemic both times, but are they significantly anemic? Are they getting worse anemia? Where are we at with this? Because if their anemia is getting worse, you put them on medical management, now they probably need a referral. Ultimately, they may need some sort of surgical intervention. For surgical intervention, sometimes they'll do a myomectomy, and a myomectomy is really they're taking that fibroid and they're plucking that fibroid out. Okay, so it's just removing that fibroid itself. They can do an endometrial ablation, so they're going through the external last, internal last, and that endometrial lining, they're using this heat wand of sorts, and they're ablating the inside of the endometrial lining, and along with that is kind of ablating that fibroid as well. Those patients, though, that is going to take away their capability to reproduce, so that affects fertility. You want to make sure that the patients that they're doing the endometrial ablation on, they will make sure that these patients no longer want to have kids that they've done in childbirth. Uterine artery embolization. Now that's a big deal. If someone comes in and they are bleeding really, really bad, Okay, and doesn't medical management, they're still bleeding to medical management. They may have to go in there and find the artery that is feeding that fibroid, and then they'll ablate that artery. They'll cut it, or they'll use heat and ablate that artery. So that is not first option, not second. That's going to be way down the line. That's probably just prior to the last thing, which is a hysterectomy. So ultimately, if these patients continue to have significant bleeding, you try medical management, and maybe they've done myomectomy, or the patient didn't want to do that, or didn't want to do endometrial ablation. The ultimate treatment may be that they need a hysterectomy. They're not going to do a hysterectomy at the beginning because hysterectomies are not without side effects, or not without complications. It's general surgery for these patients, and so we want to make sure that we try other treatment measures before we ultimately have to do surgery on the patient. Some specific indications for surgical intervention. Certainly if they failed medical management. Here's the deal, we're not making these decisions. We're not making a decision whether the patient can have surgery or not. This is our consultant. We are in this situation where we're going to apply medical management, and after that medical management, we're going to refer and say failed medical management. And then the surgeon can talk to these patients. Okay, but some specific things they think about is if they continue to have bleeding, they have persistent or worsening anemia, they're not getting better medical management, let's talk to these patients about the surgical modalities that we can provide. Rapid enlargement of a live myeloma is very concerning because usually there's a very slow growing. When you have rapid enlargement, and maybe some sort of associated cancer with that. Okay, if they have evidence of mass effect, like bowel or bladder problems, they may take them to surgery because they don't want to have that continued issue with that mass effect. Again, anybody that gets any sort of lesions or masses after menopause, these are estrogen dependent. We don't have much estrogen after menopause. Why are they growing? Or why do they develop this after menopause? Those patients are at higher risk of needing some sort of surgical intervention. And then infertility maybe as well. So when we think about leiomyoma or uterine fibroid versus adenomyosis, uterine fibroid is going to be a distinct mass. Okay, it can be in lots of different places, but it's a distinct fibrous ball of tissue. And then adenomyosis is that endometrial cells, so little tiny small cells all over in the muscle belly of the uterus. Can fibroids be in the muscle belly? They absolutely can, but again, it's still going to be a discrete mass as opposed to these punctate areas of different endometrial cells that we're going to see. Globally enlarged uterus on the adenomyosis, and then fibroids is more of that rubbery feeling. Then when it leads us to endometrial hyperplasia or endometrial malignancy is our M. Now we're going to specifically talk about endometrial cancer when we talk about our gyne-onc lecture. So today we're going to focus on endometrial hyperplasia. Endometrial hyperplasia is categorized in two groups. We have endometrial hyperplasia with atypia, endometrial hyperplasia without atypia. Without atypia, less likely to become neoplastic. Nothing is impossible, but definitely endometrial hyperplasia with atypia, we have those atypical cells that are presenting. Those patients are much more likely to progress to endometrial cancer. Okay, and then that goes along with age, right? So endometrial hyperplasia without atypia is going to be that little bit younger, if you will, so the 40s to 50s, kind of the early postmenopausal period. And then endometrial hyperplasia with atypia is going to be that late menopausal period. And think about after the age of 55, so 60s, 65, and up. Both of these can be caused by someone that is chronic exposure to estrogen or unopposed estrogen, meaning they have primary estrogen, no progesterone, or very little progesterone. Those anovulatory cycles, those put these patients at high risk. Or again, if they have early menarche, that means they're getting exposed to that pulsatile estrogen earlier on in life, so they have prolonged exposure to estrogen. These patients oftentimes are going to present with that abnormal bleeding. Okay, they may also present with asymptomatic. Okay? And what will happen is they're coming in maybe just for a routine evaluation, and you do a cervical cytology, you do a pap smear on them. And you send that cervical cytology off, they don't have really any other concerns or complaints, but the result that you get back, it says atypical glandular cells or benign endometrial cells. Benign endometrial cells are fine, maybe if they're in the endometrium, but if you're seeing them and getting them on the outside of the cervix, those are no longer considered benign. That's concerning because we're having change of those cells on the cervix. So atypical glandular cells, benign endometrial cells in patients over the age of 45, that is very concerning that they have a minimum endometrial hyperplasia. They may be an endometrial cancer. We may also, for postmenopausal patients, we may see an abnormality on an ultrasound. We may actually see a thickened endometrial stripe where the lining of that endometrium gets thicker and thicker because of the hyperplasia that's causing that. Again, think about atypia as progressing to or in conjunction with cancer, and then the tibia has a small chance but can still progress to cancer as well. Well, how do we diagnose these folks? All right, we have premenopausal versus postmenopausal. Premenopausal. When we think about premenopausal, so these patients are coming in, they're having vaginal bleeding, and I want you to think about vaginal bleeding and ultrasound, or the assessment of vaginal bleeding and ultrasound. They should go hand in hand. So for premenopausal, you're going to get that ultrasound. That's fine. The problem is this. That ultrasound is often not reliable in premenopausal patients. And I'm going to tell you why. When you get that ultrasound, it depends on what time of the month that ultrasound is done, will depend on how much estrogen we have in the system, right? So remember the beginning, we have our follicular phase, and we have our luteal phase. In the follicular phase, that is our phase that has higher estrogen levels. In our luteal phase, we have higher progesterone levels. So if we were to get that ultrasound, and we're in that middle of that follicular phase, we have those high estrogen levels, the lining of the uterus is thickening. It is preparing for implantation. So if you get it around days 10 or 11, you're going to have a pretty darn thick endometrial lining. It doesn't mean that these patients have cancer. It doesn't mean they have hyperplasia. It means they have the normal response to the estrogen that is increasing and then preparing the endometrial lining for implantation as we go to the luteal phase, right? So it doesn't mean we don't get it. It just means that we can't, it's not reliable. Just because it's abnormal doesn't mean we say, I think you have cancer because your endometrial lining is very thick. Okay? When we talk about postmenopausal patients, that is the case. When they have endometrial cancer, or when they have thickening of the endometrial lining, we do think that's very highly associated with cancer. But premenopausal patients, they can have thickening in response to that normal increase in estrogen at the first part of the menstrual cycle. We're going to get it, but it doesn't mean that they have cancer. So what we think about for premenopausal patients is an endometrial biopsy. That's going to be more diagnostic. So you have a question that says, what modality can we use to diagnose hyperplasia in a patient that's premenopausal? It is not an ultrasound. The diagnostic tool of choice is an endometrial biopsy. Endometrial biopsy, they're going in and they're taking pieces of the endometrial lining and they're sending those off to the lab for the evaluation. We're going to still do that ultrasound, but endometrial biopsy is going to be your diagnostic tool of choice. Ultimately, if we did the ultrasound, we did the biopsy, and the biopsy still is non-diagnostic, then they can do a DNC. A DNC is where they're going to go and scrape the lining of the uterus and send that tissue off, or those cells off for evaluation. In the postmenopausal patient, we're going to do that transvaginal or transabdominal ultrasound, okay? And we're hoping for an endometrial stripe that is less than 4 millimeters, or equal to or less than 4 millimeters. If it's equal to or less than 4 millimeters, it's a very low risk if there's any issues going on with this patient, or at least if it's hyperplasia or endometrial cancer, according to the American College of Oncology. If it is greater than 4 millimeters, we are very concerned that they have hyperplasia, and then again, maybe even endometrial cancer. You have endometrial hyperplasia with atypia, the management for that, so it may spontaneously regress, especially in those younger populations. Okay, so may spontaneously regress without any intervention at all. But there is a up to 3% chance it actually can progress to endometrial cancer. So what the recommendation typically is for these patients is we put them on hormone therapy, so usually 3 to 6 months of this low-dose progesterone therapy. That could be from maybe a combined oral contraceptive or progesterone-only contraceptive. But most of the time, the recommendation, because we like to avoid that estrogen in these folks, is going to be a levonorgestrel IUD. The levonorgestrel IUD is going to thin the lining of that uterus. Remember, hyperplasia is going to have thick lining of that uterus. It's going to thin or atrophy the lining of that uterus, which is ultimately going to reduce their signs and symptoms, reduce their bleeding as well. Once we put them on this the levonorgestrel IUD or progesterone-only contraceptive, then the recommendation is a endometrial biopsy every 3 to 6 months while they're on the medication. Okay, once they have 2 negative biopsies. So the intent of the medication is to completely get rid of this hyperplasia, to reduce to take their risk of endometrial cancer back down to 0 or as close to that as possible. So we're going to do that with a progesterone only. We're going to repeat that endometrial biopsy every 3 to 6 months. If that hyperplasia resolves, okay, then the recommendation, we're going to continue, just have them continue on that low-dose progesterone. Okay. If that hyperplasia continues, it does not resolve, and we have a couple of options. What they primarily were talking to these patients, or initially talking to these patients about, let's increase the progesterone content. Okay. If that doesn't work, we can also talk about a hysterectomy. So again, even for these patients with hyperplasia, hysterectomy is not the #1 thing to do. They want to make sure that they can do the best they can with medical management first. So progesterone only, or progesterone, IUD, and then our repeat biopsies. If they have endometrial hyperplasia with atypia, they usually have a much higher risk, up to 30% risk, if that is going to then progress to endometrial cancer. So these patients, the ultimate goal is to identify this early on and hopefully prevent progression to endometrial cancer. If we have a premenopausal patient that comes in and they have endometrial hyperplasia with atypia, how do we know that this is endometrial hyperplasia with atypia or without atypia? The biopsy. It's not from the ultrasound. The ultrasound just shows thickening of the endometrial lining. It's the biopsy. So both of these patients have to have a biopsy, and that's what we're going to see on the biopsy. Okay, so premenopausal patients, if childbearing is complete, we can do a hysterectomy with self-injectomy. Okay? And sometimes they'll do an oophorectomy as well. So if you take out the uterus, the fallopian tubes, sometimes they'll just do that. Sometimes they'll take the ovaries. If you leave the ovaries, we're still getting some estrogen, progesterone, so these patients won't push these patients immediately into menopause. Okay? If these patients are not done with childbearing, we can do those progesterone only. We can do the IUD. And so what they'll do is they'll insert the IUD, and they'll repeat that biopsy every 3 to 6 months. Once they have 2 negative biopsies that show that the hyperplasia is gone, they will take the IUD out, they will allow them to childbear, and then they will, once childbearing is complete, they will put the IUD back in, and then they're going to continue to monitor these patients, usually for at least 2 years. So they'll monitor them. They've got to have repeated biopsies and have biopsy negative before they'll remove the IUD. At least that's what the recommendation, that's what they're recommending to the patient. If they're postmenopausal, they just take everything out. Okay, hysterectomy with bioidosublingual oophorectomy. So they're going to do, you don't need the ovaries are non-functional. You don't need the uterus. Let's take that out. Let's reduce the risk of any additional cancers developing. If someone says, I don't want that, I want to keep all my stuff, well, they'll offer them progestins as well. You can, okay, you can just do progestins, that's fine, but the recommendation would be for hysterectomy with the so. Sometimes patients are not healthy enough to undergo surgery. This is an example of an ultrasound. Here we have the uterus, and then here we have the endometrial structure. There's a little X here and a little X here. And what happens is you don't read these. The radiologist will send something back on the report that tells you the thickness of the endometrial structure. Again, 4 or less, we're not all that concerned. Okay? It doesn't mean they don't need additional evaluation or workup if they're still having this abnormal bleeding. They probably ultimately would need an endometrial biopsy. Okay? But if it's 4 or greater, we're very concerned, especially in the setting of a premenopausal patient that has risk factors for prolonged exposure to estrogen with no progesterone, like this anovulatory cycles, or postmenopausal patients with abnormal bleeding. Although you're not going to be doing an endometrial biopsy, if you talk to your patients about endometrial biopsy and you say to them, I'm going to refer you over to OBGYN and some things that they may do. One of the things they may do is endometrial biopsy. What is that? So I put this in there so you kind of understand what an endometrial biopsy is. This top picture and this second picture here, these are sounding tools. So they'll go through the external os, okay, we can see here, through the internal os with this sounding tool. So they kind of can feel where the back portion of the uterus is at. And then they have these little grabbers that come out. And these little grabbers come out and they'll do multiple areas of the endometrial lining and they'll do biopsies of those areas. And then the grabbers come back in and they pull it out and they send it off to the lab. Depending on the provider, sometimes they'll do the endometrial biopsy under a hysteroscope, and the hysteroscope goes into the external os, into the internal os, and it's a magnifying glass so they can see into the lining of the uterus, and that allows them to actually physically see maybe some abnormal areas. Because the problem with doing biopsies is, again, we're doing areas of biopsy. We may not get the area that's affected, and ultimately say that this is negative when they actually do have a degree of cancer, maybe early onset cancer. Our non-structural causes, we can use that acronym COIN to remember our non-structural causes. The C in COIN is coagulopathy. Coagulopathy, about 13% of women with heavy menstrual bleeding have some variant of something called von Willebrand's disease. About 20% actually may have some other coagulopathy or coagulation disorder that can cause abnormal bleeding. We have systemic diseases. Systemic diseases like leukemia. Someone has chronic liver disease. Medications that can cause anticoagulants or even chemotherapeutic agents. They can cause a coagulopathy to occur or can impair coagulation or coagulation pathway. Hemophilia, so people have platelet dysfunction. They can also have coagulation disorder. So some patients know they have an underlying coagulation disorder. Some patients don't know this because they don't really seek medical care. We got to make sure we have in mind some questions that we may ask to help us rule this in or rule this out as a differential diagnosis. So if they've had babies for, did you have any problems with postpartum hemorrhage? Any surgeries? And if so, did you have any bleeding after or during surgery? What about dental procedures? Any problems with dental procedures? You have excessive bleeding? Or even do you have bleeding when you brush your teeth? Frequent nosebleeds that are difficult to control? Frequent gum bleeding with even just minor trauma? And then, of course, family history. What is your family history of any sort of bleeding disorder? Those are common questions that we use to help us identify if there's any evidence of coagulopathy. Okay, so if we don't have any evidence of coagulopathy, we can think about the O portion of our COIN, ovulatory or anovulatory dysfunction. We talk a lot about anovulatory, but even ovulatory dysfunction. Is there something that's causing that prolonged luteal phase, that prolonged exposure to progesterone secretion where now they're bleeding more, okay? Or at irregular times. Maybe we have low levels of estrogen. With anovulation, remember anovulation, we have those higher levels of estrogen, but the estrogen doesn't get all the way up to that 200 picograms, so we're kind of stuck in this constant state of 51st days of estrogen exposure, where it's just consistently having all this estrogen exposure, and ultimately we have sloughing off of the endometrial lining at irregular times because the lining of the endometrium has outgrown its blood supply. A lot of times, these patients, especially as they're going towards menopause or earlier on, they'll have these mixed anovulatory and ovulatory phases that they go through. Anovulatory and ovulation can occur, abnormalities can occur at those extremes of age and not be abnormal at all. Early puberty and late reproductive time period, just before they go through menopause, they're going to have this mix. And so they oftentimes will have irregular cycles. Again, don't be fooled by that and just say, well, it must be anovulatory and ovulation because of your age. There are other things that can be, so just keep that in mind as a differential. Certainly if someone's lactating, a lot of times they'll have mixed anovulatory and ovulatory cycles. If they're pregnant, they are not ovulating at all, right, because of pregnancy, so they shouldn't have bleeding in pregnancy. If they have evidence of hyperandrogenism on physical exams, or excess acne, maybe excess hair development like PCOS, that can be causing abnormalities. And then hypothalamic dysfunction, so GnRH. GnRH is going to affect FSH and LH release, which is going to affect estrogen and progesterone. Excessive weight gain or excessive weight loss oftentimes is going to cause irregular menstrual cycles. You think about the female athlete triad, and those patients oftentimes are going to have irregular menstrual cycles. That brings us to our E, I, N of our corns. Endometrial atrophy, or a type of endometrial hyperplasia, but also endometrial atrophy. As someone goes more towards menopause, they'll have atrophy of the endometrial lining, they'll have irregular bleeding. Endometriosis, that's that bleeding, the endometrial cells outside the lining of the uterus. These patients will have not only pain with menstrual cycles, but also irregular bleeding. Iatrogenic, there's an IUD, or if you put someone on Depo or progesterone pills or oral contraception, can those affect how these patients' menstrual cycles? Certainly. We talked about that yesterday, that they initially can have increase in their bleeding and then ultimately can have decrease and then no menstrual cycles at all once they're on these medications for a period of time. And then not otherwise specified, we think about that really as an infection, like cervicitis, STIs, PID. That's usually rolled up into that not otherwise specified. AV malformations, that's like 0.01% of the population. Now, if someone has an AV malformation that starts to bleed, they are going to bleed to death very quickly because those patients bleed terribly. So the mechanism of action behind anovulatory bleeding. Do we have an LH surge that occurs? We don't. Do we have continuous estrogen that's occurring?
Yeah.
Yes. Okay. What about the follicular phase? Are we progressing to the follicular phase?
No.
We're stuck in the follicular phase. We're not progressing to the luteal phase. Corpus luteal formation? No, because we're not having that LH surge. And then excess progesterone? No. Excess estrogen production. All right, so when these patients come in, abnormal uterine bleeding, the first thing we want to do is we want to make sure that this is uterine bleeding. And I use the word abnormal uterine bleeding because that's where it's coming from, right? It's coming from the uterus, but where it's coming out of the vagina. And I say that because we did have a student not that long ago who was like, well, I didn't understand what you mean by abnormal uterine bleeding. Well, it has to come out somewhere, and it's not going to come out posteriorly, it's just going to come out of the vagina, but it's coming from the uterus. So how do we know it's coming from the uterus? We do a physical exam. We look, do I have blood that's coming out of the cervical os? It's coming from the uterus. Because you could have a vaginal laceration, that's not coming from the uterus. Okay, so we want to make sure it's coming from the uterus. You could have a urinary tract infection, and patients will come in and they'll say, when I wipe, I notice blood. That doesn't tell me it's coming from the uterus, it's telling me it's coming from somewhere down there. I got to figure out where down there is, and I do that by doing a physical exam. You want to make sure you do that history, good history on these patients, not only a personal history, but family history as well. Make sure you're looking for evidence of hyperandrogenism. looking for acne, because that's going to help guide your laboratory evaluation of these patients as well. HCG, CBC, okay, those are very commonly done in patients with abdominal bleeding. I would add liver enzymes in there, and that could be in the form of a CMP, or you could do a BMP, basic metabolic panel with liver panel. But either way, I would add liver enzymes in as well. What about coags? You know, potentially that you need coags for these patients, PT, PTT, INR, depending on what you might think of their underlying causes of the abdominal bleeding. Cervical cytology, a pap smear, maybe, especially if they haven't had one in the time frame in which they were supposed to have one. That would be a consideration. And then imaging. The majority of these are initial imaging is going to be a ultrasound. It's going to be a transvaginal ultrasound. Transabdominal can be considered if they can't tolerate the transvaginal ultrasound. If additional studies are needed, like a saline infusion scan or sonohysterography, that's usually done by our consultant. So for us, it's going to be that primary, that transvaginal ultrasound. And then consider referral. These patients they don't respond to medical management. They have a history of excess estrogen exposure with unopposed progesterone. They consistently bleeding more and more and more despite our interventions with medical management, which can be combined oral contraceptives or progesterone IUD. Okay. One of the things we talk about when we think about labs, we always throw TSH in there. And you maybe remember from endocrine, but TSH can affect all sorts of things. But one thing it can affect for us, and we're going to talk about, is the HPO axis. So if you have low T4, that low T4 is going to kick out thyroid-releasing hormone, it's going to kick out thyroid-stimulating hormone, but it's also going to kick out prolactin. Okay, so what happens? When you have high prolactin, that's going to suppress GnRH. GnRH is important for us to our anterior pituitary to kick out FSH, LH, and ultimately for estrogen and progesterone to be regulated correctly. So anytime we have abnormal TSH, ultimately it's going to affect that entire, or the potential to affect that entire HPO axis, which can cause these patients to have these irregular cycles. Could be heavy, could be light. This is just an algorithmic approach. These patients come with abdominal bleeding, they're premenopausal. We're going to do our history and physical exam. We're going to make sure that they're not pregnant. We're going to check those labs. And if those labs are abnormal, we can manage the level. If the thyroid's high, the thyroid's low, then let's treat hyper or hypothyroidism. But if all of our labs or evaluation is normal, then let's order that ultrasound. And that ultrasound, we already know in premenopausal patients, we're not only going off that endometrial stripe, we're looking for irregularity in the lining of that ultrasound. So we're looking for the structural abnormalities, the myoma, the polyps, adenomyosis. We're looking for all that with our transvaginal ultrasound. If there's evidence of abnormal appearing endometrial stripe, EMT is endometrial thickness. So if it's abnormal, we want to keep that in mind and then make sure we've asked the questions that tell us if this patient has had long-term irregular menstrual cycles, long-term exposure to estrogen without progesterone. And if that's the case, we need an endometrial biopsy. If the endometrial thickness is normal, the lining of the endometrium looks fine, we can try these patients on medical management, combined oral contraceptives. The Levonorgestrel IUD is usually the treatment of choice, at least initially. They fail medical management, they need a biopsy. We got to figure out why are they not responding to medical management. And then ultimately, depending on what that biopsy shows, they may need some sort of definitive treatment, endometrial ablation and hysterectomy. For the postmenopausal patient, still an algorithmic approach, but what number do you see all over this chart? 4. It should remind you of the billboard. Jeff Davis, call the 4s. Because if you don't catch this, and this person has endometrial stripe greater than 4, you're going to be calling the 4 because he's a lawyer and you're going to need a lawyer. So let's call the 4s Jeff Davis, right? So if we have an endometrial thickness less than 4, less than or equal to 4, okay, and these patients do not have a high risk for prolonged estrogen exposure, it's okay to try them on medical management observe and come back in a month or so, come back in a couple, 6 weeks, let's try something, and then reevaluate. Right? If we observe them, they're still bleeding, they're really not getting better, they need to go see our consultant. And then they can decide what to do. They might do a hysteroscopy with a DNC, they may need to do an endometrial biopsy, but for sure, if they have high risk for estrogen exposure, they have a thickened endometrial stress, those patients need a biopsy. They need to be referred for an endometrial biopsy. Can you put them on medical management while you're waiting for the consultant to see them? Sure. Sure, we can help try to control this bleeding because they're going to continue to bleed. But ultimately, even if they say, I feel much better, I took the IUD was placed, or I took the hormonal contraceptive, things are much better. Do I still need to see OBGYN? Yes, they still need to see that. We didn't fix the problem, we just helped with the problem. Okay, it's a temporary solution. So they need an endometrial biopsy. When you treat these patients or evaluate these patients, think about your differential. If it was not in your differential, it's not going to be in your diagnosis. So think about your differentials, and then think about the ultimate treatment. Usually it's going to be some sort of hormonal therapy, oftentimes progestin therapy, okay? And then surgery if they fail medical management. If we have non-structural etiology, we've got to identify what the non-structural etiologies are based on our COIN acronym. So then these patients might come in to see you and they say, I have acute abnormal bleeding versus this chronic abnormal bleeding. Acute meaning I have been bleeding, but now I am every hour I'm changing my sanitary product. I cannot even leave the house. Just from walking down the hallway, I've already feel that I'm so confused. I have acute bleeding on top of my chronic. Okay? Those patients might be unstable. Unstable, or tachycardic, hypotense, H&H is dropping. Those patients need immediate intervention. Or they might be stable. Okay, so we've got to figure out first, are they stable or unstable? Okay, and then we decide what treatment we need. If they are chronic abnormal uterine bleeding, we can monitor those patients. We can provide intervention, but we also can just monitor those patients while we're undergoing additional evaluation. So if they're coming in, they have an increase in their chronic abnormal bleeding, and now this is more acute, but they're stable. We can give them combined oral contraceptives, the same pill that they may be on now, but now we're increasing the dose. We're having them take one pill every 6 to 8 hours for the next week. Okay, and that will help normalize their hormone levels and hopefully cause some endometrial atrophy and reduce their amount of bleeding. We could give them a progesterone-only pill, or we could give them an injection, a depo-medroxyprogesterone injection, so a Depo-Provera injection. We could give that to them in the clinic. The problem with the injection, it's not going to work immediately, and we already know we do have a risk for increase in bleeding after the first injection for the first few months. Okay? We could give these patients tranexamic acid. We could give it orally, or you could give that IV if they're having significant bleeding. If they're unstable, or we've tried these medications, we say, come back and see me the next day, or go to the emergency department if you're not doing any better. If they're unstable or they're not responding appropriately to the medical management, then they need to see the consultant. And then the consultant decides what they're going to do. They may need a DNC. They may need something called a balloon tamponade. So balloon tamponade is a big giant Foley that they put inside the uterus, and they blow it up and they compress the vessels. Okay, so we can have decreased bleeding. Uterine artery embolization, that is not something they do at the beginning. That's not the first thing they do. But if they're bleeding profusely, they're going to find the main uterine artery and they're going to embolize that main uterine artery. And ultimately, when they do that, these patients will have to have a hysterectomy because they just cut off all blood supply to the uterus. And then lastly, again, is that hysterectomy. These are some IV medications. And for these patients that come in and they are acutely bleeding, they are unstable, we can give them conjugated estrogens IV. Again, and even if if they're stable, you can still give them these medications, but some of them they'll take at home. So medroxyprogesterone, and then TXA is on here as well. Could be IV or could be PO. Nothing, you don't need to memorize anything on you. This is just some additional information. If they come in, so that's for our acute. I have chronic bleeding, but now it's worse. Now it's worse. Increase the dose of your combined oral contraceptive. Give them an injection of progesterone, put them on for something progesterone only. Okay? If that's not better, then we need to talk to a consultant. If they come in and they have chronic, but it keeps coming back, it's not really getting any better, it's not really getting any worse, okay, but I'd like a little bit better control of this, we can do endometrial suppression for these patients. Okay? Often, most patients will need is endometrial suppression. And this is usually in the form of a placement of an IUD. The monogastric IUD is the most common thing we're going to use for endometrial suppression. And what does ultimately the monogastric IUD do? It causes endometrial atrophy, and that's what we want. We want to atrophy the lining of the endometrium to reduce the amount of bleeding they have. Again, we can still use progesterone only birth control pills. The problem with progesterone only birth control pills is they got to be regular when they're taking those. 3 o'clock every day. Okay, if they're outside of the window by an hour or two, now they're just ruined, disregarded what that initial progesterone is. So it's got to be very regimented in taking that birth control pill. Okay, we do extended cycles. Okay, again, they may have increased bleeding at the beginning, but if I put them on that extended cycle, we're ultimately resulting in endometrial atrophy, and hopefully we can pull these patients so they're not having that increased bleeding. And then depot as well. So depending on what they're on now, will depend on what you change to or what you add. We can normalize the prostaglandin. We can do that with anti-inflammatories. Now, I know it sounds counterintuitive that we're giving someone like an ibuprofen or naproxen that is aspirin-based that's already bleeding, but remember, we're reducing those prostaglandins. If you reduce the prostaglandins by giving that prostaglandin inhibitor, and it reduces the amount of bleeding that they have as well. And this works best, and primarily if they're not already taking the anti-inflammatories. And we're not talking about taking these when you want. We're talking about 600 to 800 milligrams of ibuprofen every 8 hours for the next 7 to 10 days. So make sure they don't have any GI issues before you have them take those doses. We can do something called coordinating endometrial sloughing. And what we're doing here is we're giving the endometrial lining a break. We are going to give the patient a progesterone that takes over that luteal phase. And we talked about this our second lecture when we talked about amenorrhea and pushing these patients into a menstrual cycle. But here, what we're trying to do is give the endometrial lining a rest by giving them either estrogen and progesterone or just progesterone to take the onus off of the body for those hormones. And then TXA. There are patients that chronically have very heavy menstrual cycles, and they are told to take TXA either the day before their menstrual cycle starts or the day of their menstrual cycle. You take it every day during your menstrual cycle, and that helps control the amount of bleeding. Usually about 650 milligrams or so. We don't need the dose, but it helps that. And then we want to make sure that we're managing this chronic anemia. We want to evaluate and manage this chronic anemia. For surgical management for that chronic reoccurrence. Okay, first of all, we got to figure out, is this an underlying structural issue that we need to send these patients to our consultants for surgery? Have they failed our initial medical management or repeat medical management? Is childbearing complete? Because if so, then they may offer these patients an endometrial ablation. Okay, that's about 3/4 of the patients that have endometrial ablation get complete relief of their abdominal bleeding. Or they may offer them a hysterectomy, depending on what the outcome is and what if they completely get childbearing or not. Usually for these patients, if they're doing a hysterectomy just for abdominal bleeding, they usually do not do a BSO, a bilateral self-evaluation. Why? Hormones. We want to let them have the hormones. They don't need the, they're not saying they have cancer. Okay, so we want to leave. You can do a self-injectomy, but you leave the ovaries, provides them that continuous basis of hormones, so they'll push them into their ultimate cause. Ultimately, stop the bleeding if we can, or at least control the bleeding. We want to prevent this constant reoccurrence of the bleeding, avert not only morbidity but mortality as well. Okay? And then these patients deserve a good quality of life, so if we control this bleeding, that certainly helps with that. If they're anemic, put them on iron in addition to treating for this abnormal bleeding. And then recheck, you don't put them on iron once and never recheck them again. Recheck an H&H in a month or two. Make sure that it's stable or your H&H is improving, okay? And then remind them, you may get worse before you get better. Be patient. Be patient with the treatment, trust in the process. I'm gonna have you come back and see me, so we keep monitoring you, but you may get worse before you get better. As soon as you say that, they're not gonna like it, but it's true. All right, that is it for today, thank you.